Gabriel Garcia is an assistant professor in the Stewart School of Industrial and System Engineering at Georgia Tech, where I am at too. So she's one of my colleagues, and we actually started working together in a few projects. His research focuses on design, analysis, optimization, using data, and it's at an intersection between predictive analytics, and decision making. He's been motivated by the need of working on fundamental methodology, but he is also motivated by data-driven modeling and high-impact problems in healthcare, including chronic diseases, concussion, opioid-related overdose, and maternal health. So I hope those are on the call that they heard that their area. Hopefully they'll contact Gian soon. He's been awarded several paper awards. Actually, also it's a scholarship that is quite well known in my field, Informs Wagner Scholarship for Operations Research and Health Services Research. He has an HRQ grant. He's in his third year, I think, so he's still starting. It'd be great to connect him to start working on NIH grants as well. Before he joined IISE, he was a postdoctoral fellow at Harvard Medical School. He earned his Ph.D. and M.S. from Industrial Operation Research Engineering from University of Michigan, and then his BS from Industrial Engineering at the University of Pittsburgh. I will let Gian to add if he needs to, or just get started on his presentation.
Thanks, Nicoletta, for the very detailed and kind introduction, and I appreciate the shout outs. And I also want to thank Jeff Mills for the invite and all the other folks at the GCDTR who helped make this possible. This talk, I kind of designed it, and I like to do my talks as engaging as possible. So if at any point anyone has a question, please feel free to interrupt me. I won't take it personally. And I'm happy to answer questions as best I can. So without further ado, I'm going to go and start my presentation on designing responsible AI for diabetes care. So before I get too deep into the talk, I want to acknowledge the research team that helped make this work possible. So the bulk of this work was led by my PhD student, Chai Liao, who is a PhD student in machine learning here at Georgia Tech. Some of the work was also done by an undergraduate student I've been advising, Vivian Yang, who is a double major in IISE and math here at Georgia Tech. And then there's been several faculty, including Esmail Kevanshoku at Texas A&M in the business school, and then Francisco, Kui, and Mary Beth, all here at Emory. So this is quite a methodologically diverse team, which I think speaks to kind of all the aspects of responsible AI that we want to account for in designing this work. I like to start a lot of my talks with good news. So the good news is that it appears that AI is not replacing clinicians anytime soon. So I was, doing some Google searching for news articles related to AI and medicine and AI in healthcare, and this one caught my eye. So in Politico, they interviewed the current president, I guess the new president of the American Medical Association, Jesse Ehrenfeld, and Jesse says that he doesn't think that AI is going to replace clinicians. And the interesting thing here is he says that physicians who use AI will replace those who don't. And I think the key takeaway here, and this is something that clinicians have been and physicians have been dealing with for a long time, is updating their skills to match the technologies that are emerging. And so, it seems AI is here to stay, and physicians who know how to use that technology will be at an advantage. That being said, AI in medicine does not come for free, and it isn't, going to do all these amazing things that we want it to do, just as it is. It is well known that in some cases, AI in medicine and a lot of other areas, for example, in criminal justice, have shown bias. And this can be owing to all sorts of different routes. So for example, in some cases, the data that is being used to train these AI models might in itself be biased, or it could be that the underlying objectives of these AI tools are not accounting for equity or fairness or any number of other factors that can make these tools useful and clinically acceptable. And so it is, these are kind of the issues that are motivating the talk I'm giving today on responsible AI. And I do want to point out that this terminology of responsible AI has been around for a few years, but it's really come to the forefront very recently. So the White House actually announced an emphasis on promoting responsible AI, which encompasses a whole lot of different aspects, including privacy, equity, etc. But I do think that this renewed call and interest in designing responsible AI should be something that we think about, given the high stakes nature of the work that we do here in healthcare. So in this talk, my goal is to design responsible AI technology for diabetes care. And you might be asking, well, what does that mean and what does that look like? So throughout the rest of this talk, I'm going to continue to motivate some new technology that we've been developing and kind of demonstrate the different steps we took to design it responsibly and what future steps we have. I will also add that, being in IISE and being someone who's very much interested in developing fundamental mathematics for these types of models, I'm doing my absolute best to have as few equations as possible. So, at any point, I'm happy to chat more about details, but I'm hoping that I'm able to convey some of the key ideas as well as I can. And if something's unclear, again, please feel free to stop me. So the work that we developed for this talk is motivated by type 2 diabetes. It's one of the most common chronic conditions here in the US. And to make matters worse, a significant proportion of people with type 2 diabetes are also affected by hypertension. So hypertension is also known as high blood pressure. And people with So hypertension, first of all, is a key risk factor, a main risk factor for cardiovascular disease, which is sometimes the leading cause of death in the US. Sometimes it's cancer, but they trade off. But to make matters worse is that people who have both type 2 diabetes and hypertension tend to be at an increased risk of cardiovascular disease, heart failure, and a host of other issues, such as chronic kidney disease. And beyond that, this combination of comorbid type 2 diabetes and hypertension is especially common among racial minorities, the elderly, and people from low socioeconomic status. And so we want to make sure, as we're designing clinical decision support tools or AI technologies that are aiming to facilitate the treatment planning for people with comorbid type 2 diabetes and hypertension, that we're being sensitive to people from these populations, in the sense that we're, making sure that we're not biasing our models against them. So where does AI play a role in all this? It turns out that managing patients with multiple comorbidities, such as type 2 diabetes and hypertension, can be really challenging. Treatment planning has to account for and balance different risks and benefits of treatment decisions. And sometimes that's not the most straightforward thing. So this is where we believe there's an opportunity to bring in AI, which can more quickly account for all these competing risks and benefits, to be able to inform how treatment planning occurs. And in particular, the technology that we are interested in is called counterfactual explanations. This is a new type of AI that could facilitate treatment planning for patients that have multiple comorbidities. And in our case, we are kind of developing and testing it for patients with comorbid type 2 diabetes and hypertension. So how does this work? So this counterfactual explanations algorithm works by recommending what we're going to call digital role models. So the idea is you have a patient come into the clinic, and based on some risk assessment tool that you have maybe embedded in your electronic health records or some proprietary tool that you use, you identify that this patient is high risk for some outcomes. So for example, cardiovascular disease. And you go and you're trying to figure out, well, how should I best treat this patient? And so you take this patient and their characteristics and you plug it into this counterfactual explanations algorithm. And what the algorithm does is it goes through the patient database and it tries to find a patient who is as similar to the high-risk patient as possible. But the only difference being that, or the main difference being that this new patient is low risk for this outcome. So for example, we have someone who's high risk for cardiovascular disease. Our algorithm looks for someone who is low risk for cardiovascular disease and is very, very, very similar to our current patient. And this is the person that we're calling the digital role model. We use the term role model here because we believe that this low-risk patients, different physiological measurements and lab measurements can help to inform treatment targets. And you can also look at their current treatment regime and try to see, is this a feasible treatment route to go with the high-risk patient? And so the idea is to be able to find this low-risk patient, this digital role model, study them, and develop some treatment recommendations. So at this point, I want to stop and see if there are any questions about kind of the key ideas behind this algorithm that we're developing. Yeah, I'll stop here for a second. All right. So it seems there are no questions. So I'm gonna keep going. Again, if you want to stop me at any point, feel free. So this is, again, we want to use this counterfactual explanations algorithm. And our question here is, can we design this algorithm responsibly? As I mentioned, there's very many ways of thinking about what it means to design a responsible AI algorithm. And for our work, we kind of focus on three facets of responsible AI. The first of these is robustness. We want to develop tools that are robust to shifts in data or shifts in the environment or shifts in the population. We essentially want to make sure that if we build a tool, it doesn't break down when we try to, over time or as we change, the data setting that it's in. We also want to develop tools that are largely considered to be interpretable, and especially for high stakes settings like healthcare, where people literally make like life or death situations, developing tools that the key stakeholders, for example, clinicians and patients, really understand why it's making the recommendation it's making, and how that can inform the treatment decisions. We think this is a super critical aspect of responsible AI, and this is something we strive for in our work. And then finally, we're interested in fairness, and fairness here being the case where we design an algorithm where our goal is to make sure that we're not putting an undue burden or increasing the risk of adverse outcomes for some groups over others simply because of how we designed our algorithm or because we did not curate our data well enough to train the algorithm in a fair way. So these are kind of the main facets of responsible AI that we're focusing on. And the intersection of these three, again, is kind of our notion of responsible AI. I want to add here that The bulk of the work that we focused on so far has been primarily on the robustness and interpretability points of or facets of responsible AI, and we have been developing some work on fairness, and that's still a little bit of a work in progress. We're still early on in that stage, but it is something that's important to us. So I'll kind of share each of these results as we get there. So in this model, when you talk about robustness to data shifts, what does that mean? The key idea that we wanted to hedge against was being robust to shifts in the risk estimation model. So for example, you might imagine that your EHR has some built-in risk scoring algorithm. And as the algorithm collects more data, as new patients join the health system or as patients have more follow-ups, the algorithms are always trying to improve themselves. So for example, risk estimation tools might be retraining periodically. And so you can imagine we can essentially consider different versions of this risk estimation tool. It might not be the same today as it is, a couple months down the road. So what we want to avoid is the following situation. So suppose today you have a patient come in and you use your algorithm and the risk estimation tool says, hey, this patient is high risk. So you use our counterfactual explanations algorithm and it gives you a digital role model for this patient that says, okay, if you kind of meet the treatment targets set by this low risk patient, you're going to be low risk by the next time we see you. And then sometime between now and the next follow-up, the risk model updates itself. Maybe there's new data collected, or maybe there's some periodic updating rule that the risk model uses. And at the next checkup, the same patient comes, they've done everything you've asked them to do. They've met the treatment targets, but because of the model being updated, it now considers this patient to be high risk. This is something we want to avoid. We want to make sure that whenever we recommend a digital role model, if someone follows it to a T, that they end up being low risk in the future. So how do we avoid this problem? Well, in our case, our approach was to leverage the tools that were available to us in mathematical optimization. And we specifically formulated the problem of finding a digital role model using mathematical optimization. So the way we designed this was first setting a goal for a model. We wanted to minimize the amount of effort needed to reach the digital role model or the treatment targets set by the digital role model. Effort here is kind of flexible. We can define it pretty broadly. We use what's called percentile shift in our analysis, that says, like, for example, if I'm asking you to go from the 90th percentile of blood pressure to the 80th percentile, that's a 10% shift. And we would just add this up across all variables. But in general, our model is flexible enough to account for a lot of different definitions for effort. And this is also how we kind of, in part, impose that we want someone who's very similar to our high-risk patient. We want it to be the lowest effort. So someone who's similar to a high-risk patient is going to be relatively low effort. We also wanted to impose additional constraints on our model. So I mentioned robustness, and this is actually this constraint here in purple. And the idea here is that we want the role model that we select to be low risk in the future with high probability, where the uncertainty here comes in the risk estimation tool that I mentioned earlier. So again, if you have a risk estimation tool that's kind of updating over time, you can have very many versions of this risk estimation tool or risk scoring tool. And we want to make sure if the role model is currently considered low risk, we want it to also be low risk with high probability in the future. And then finally, we have this constraint that the role model is a real person. We don't want to generate a fake patient because we might suggest something that's not physiologically possible to do. And we also want this role model we want the changes to be actionable. And that's what I mean here by feasible for our patients. So for example, we're not going to ask someone to change their demographic features like their gender or race. And in some cases, we might ask them, there are certain aspects of the medication regime that might not be considered feasible. So for example, if someone's currently taking blood pressure medication, we probably don't want to recommend them someone who isn't taking blood pressure medication, because that's not really a feasible change for them to make. So we kind of have a bunch of rules about what some of these feasibility constraints look like. But in general, the idea is we want to pick a role model who is whose changes are going to be actionable for our patient, our high-risk patient. This is the only spot where I'm going to introduce some math, and the reason why is because this is where the secret sauce is. So if we take this kind of this math problem that I mentioned in words, the key idea here for us to impose some form of robustness, it comes in this purple constraint where we are considering all possible probability distributions that are close to the historical data on our risk estimation models. So for example, if you have historical data telling us what the parameters are of these risk estimation models, we want our role model to have been feasible for a large proportion of those, and also for all other possible distributions across those risk estimation models that are reasonably close. I also want to make a note about interpretability here. Part of the reason we're interested in this counterfactual explanations algorithm is because this idea of digital role models can be largely considered interpretable. So for example, if you have a patient come in, we know their age, their blood pressure, and their A1C, and we have another digital role model that we picked out from our algorithm, you could kind of directly compare the two and say, well, it looks like our role model has lower blood pressure and A1C, so these might be good treatment targets. And this can inform how you decide what potential changes to make to medications. But I do want to point out that this kind of eyeballing it and making comparisons this way it can be reasonable if you only have a few variables to consider. But what if we have a lot more variables or data about the digital role model? And so we wanted to actually design two interpretability metrics. And these were designed to help interpret the recommendations that the digital role model was giving. So the first was, we called it the contribution to transformation cost of a feature. And the idea here was we wanted to quantify if you change, for example, your blood pressure to the digital role model's blood pressure, how much is that contributing to the overall effort that you need to kind of reach the treatment target set by the digital role model. So for example, like if most of your shift is from going from, say, your current blood pressure to the digital role models, then that's going to comprise the largest proportion of this metric. We also wanted to look at what we called the average relative importance of risk reduction related to a feature. And basically what this means is if we were to change our measurements from what it currently is to what the digital role model currently has, then how much does that reduce our risk? So this is, if we're not, there's kind of two aspects of this. With the digital role model, again, we want to have as least effort as possible to meet these treatment targets, but we also want to reduce our risk enough so that we are considered low risk. And these two metrics help measure both of those features. So at this point, I'm going to talk about our numerical experiments, and I'm going to stop for a second here to see if anyone has any questions at this point.
Hi, this is Mega. Could I ask a question? And maybe you're going to get into this more, but I was just curious about what sort of data you are using for training the model, which it sounds like you might be getting into, but I was just curious if this is all going to be, you're limited to maybe what is captured in an electronic health record, I would imagine, correct?
Yes. So I'm gonna get into kind of our data and like kind of numerical setup soon. And I actually, it's interesting that you brought up kind of the limitations in terms of what's available in the EHRs, because like that's kind of an area we're thinking about in terms of future work to expand on. But I can get into more details about like the impact of that and like what that means in terms of our like modeling results and stuff. But that's a great point. I mean, again, this algorithm is very data dependent. And so the way we think about data and the way we curate data for these models is super important, which we've come to learn.
Mm-hmm. Okay, thanks. Yeah, I'm sure I'll have some other questions as you get further along with that. Okay.
Any other questions before I move on? All right. So we trained and tested our algorithm on data from the Accord trial. So briefly, if you're not familiar, the Accord trial was a randomized controlled trial in I think it was in the mid-2010s, where the patients were largely people who had diabetes and high risk of cardiovascular disease, and they tried both kind of like standard of care versus intensive blood pressure control and glycemic control for these patients. So not quite EHR data, but it has kind of this, it lets us kind of generate a database of patients where we have a lot of characteristics about them. And the cohort that we looked at has roughly 10,000 patients who are on average 63 years old. The majority of them are male and white non-Hispanic, and all of them have diabetes, and a large proportion of them have very high risk of cardiovascular disease. So that being said, we generated our risk model based using a similar framework that was created by Basu et al. In 2017 for predicting risk of cardiovascular disease. So they generated like a Cox proportional hazards model. So it's a type of survival model, and they used elastic net regularization to control and perform variable selection essentially. So for our case study, we used this 5-year risk model, and we picked a high risk threshold of about 20%, which is quite high for 5-year risk. But keep in mind that our cohort here is very, very high risk for cardiovascular disease to begin with. So in the absence of other data sets, this was kind of the best we could do to demonstrate our algorithm. And we generated different versions of this risk model using essentially bootstrapping. So we randomly sample from our data set with replacement to generate different versions of it. And we use kind of like a block-based cross-validation scheme to evaluate our model. So we're not kind of like training and testing on the same data. So I want to first give an example here of what a digital role model looks like and what we can do with it. So if you look at this column here in the red, this is the characteristics related to our very high-risk patient. It's a 62-year-old male who is identified as white, who does not smoke, and has no history of cardiovascular disease. If you keep looking down the list, you'll see that they have quite high blood pressure, BMI, cholesterol, and a bunch of other measurements. And after we ran our algorithm, we were able to produce this low-risk digital role model. So this person, is a 66-year-old instead of 62, but for a lot of other characteristics is more or less the same. So same sex, race and ethnicity, same smoking status, and history of cardiovascular disease. And you'll see some differences in terms of clinical measurements. So for example, our low-risk digital role model has lower blood pressure compared to the high-risk patient. Also has, different lower cholesterol. And, you can see there's kind of a long list here of variables. And you might be wondering, well, what do I target? And when we go back to our interpretability metrics, we can look at kind of these variables where this third column pertains to the contribution of a feature to the transformation cost. So in general, like how much effort is it going to take to change from whatever the high-risk patient has to whatever the digital role model has? And we can see here that these three measurements here, so, pardon my butchering of the pronunciations of these, but alanine aminotransferase, urine albumin, and the urine albumin creatinine ratio. These seem to be the features that if we were to change from whatever the high-risk patient has to whatever the low-risk patient has, these would take the most effort or the most shift in terms of percentile. And if you're interested in which changes are going to lead to the greatest reduction in risk, you'll see that it's actually these variables here, so the urine albumin and the urine albumin creatinine ratio. So from a clinical standpoint, how would we use this? Well, you might be interested in saying, well, we should maybe focus on reducing these two at the bottom, the urine albumin and the urine albumin creatinine ratio, because these seem to relate to the largest reduction in risk, in cardiovascular disease risk. I think there's some interesting points to be said here where you'll see that the low-risk digital role model has lower systolic and diastolic blood pressure than the high-risk patient, but is still high risk. And potentially surprisingly, even if you were to reduce from, say, 192/99 to 145/75 blood pressure, it actually is not going to drastically reduce the risk, according to the risk estimation models that we were using.
But how can you attach to go from nephrotic range proteinuria? We can go into that, but we don't have to at the moment. To a normal ratio is really, really hard, maybe impossible. So how can you calculate a, it may have wonderful relative importance, but I don't know how you figure that's going to only cost whatever 5.66 units compared to lowering A1C.
Yeah, that's a good point. So I will say, not being a clinician, there's certainly aspects of this that, like you mentioned, that I'm not particularly knowledgeable about. So maybe that shift is not really something that is feasible. So there's a couple approaches that we're considering in our future work. So for example, instead of generating one role model, we might generate several with the hope that one of them presents a potentially more feasible change in terms of suggested variables. But there's also the possibility that we could change how we're measuring the importance of different features. So I think in this case, this is kind of more of one where it seems that the suggested features here maybe are not ideal for this high-risk patient. But if we were to generate several role models, then we might find the one who is more feasible. So again, this is kind of part of the work that, I'm glad you brought this up.
I mean, the model seems to be to have modestly more cost in some way than lowering hemoglobin A1C. Or actually, I don't understand what's being done. It says 5.9 to 7.8. Why would it get worse? I mean, why don't you go on ahead and we can talk about these at the end if we have.
Yeah, no, that's a good point, right? Like the A1C. So that's something I imagine where it's like, you wouldn't recommend to the high-risk patient to increase their A1C. But yeah, that's a good point. I will say something that we did notice with these, and this is related to kind of the variables that are being suggested, is if we look at the medications that are prescribed to each of these patients, we can start to tease out some differences that could perhaps inform a strategy moving forward. So for example, here I highlighted all the differences between them, and in green are the top three. So for example, the high-risk patient is not on ACE inhibitors, but the low-risk digital role model is. We also see that the high-risk patient is not on statins, but they're on daily aspirin use, whereas the low-risk role model is on statins, but not daily aspirin use. So these could potentially inform the, like, maybe a switch in medication. And in particular, maybe a path forward for reducing the urine albumin and urine albumin creatinine ratio. But again, these are still, of course, our preliminary results, and I don't know I guess what thoughts are on kind of this kind of switch in medication, or if this is feasible or not.
Yeah, the switch in the meds is pretty standard stuff. The benefit, depending on the outcome that's envisioned, statins are important for diminishing cardiovascular risk. This patient's the elephant in the room for this patient might be kidney failure.
Mm-hmm. Yeah, so I mean that could be like, this could also be related to, like, again, something that we're building into like future iterations of this model, but like as of right now, we're primarily testing it on cardiovascular disease risk. But as I mentioned in the beginning, the reality is with these types of patients, you have several adverse outcomes that you're considering at the same time. So for this patient, maybe we should have included risk models for like chronic kidney disease or kidney failure, in addition to cardiovascular disease. And then maybe that can inform a better role model. Yeah. Any other thoughts on this before I move on?
So again, I had a question. So
Yep.
is this model developed on cross-sectional biomarker data and assessment of mortality relative to the cross-sectional data? So it could be that like late-stage kidney failure is like or end-stage kidney failure is the final outcome, but in reality, you might be assessing it for a patient at that time point.
Yeah, I mean, so the risk estimation models are based on longitudinal data, since they're survival models, but the data that someone has coming in, like when we're assessing them with their algorithm, is cross-sectional. That makes sense.
Yeah, thank you.
Yeah. Other questions or thoughts?
When you present this, you might note that rosiglitazone, that's okay. The logic of using rosiglitazone versus pioglitazone might not be clear, and it's not clear to me. So I'm not sure what that's based on. We can discuss it later.
Okay, yeah. And again, this is kind of like the digital role model is kind of like, this is just what they're taking. And certainly there is room for kind of like clinical interpretation and discretion in kind of taking these recommendations and modifying them. But I'm happy to chat afterwards as well to kind of refine this, because I think that's something that we need to be thinking about moving forward. All right. So based on these results, I've mentioned before that like when we have these data-driven systems, it could be the case that the risk estimation model, we're going to have many versions of this over time, and we might be interested in the distribution of risk across across all these different versions of our risk estimation models. So here we plotted the distribution of our high-risk patient versus a role model that we generated, where this is the distribution of the risk scores based on the various versions of risk estimation models. And you can see here that our high-risk patient has, their risk scores are all in this very, very high range, whereas the role model here, we can see that for the most part, I think it actually is all of their risk scores are below this threshold of 0.2. So this is an example that kind of shows the importance of making sure you account for this uncertainty in the risk estimation models, because again, you don't want to make recommendations to someone, they come back and it turns out that they're still high risk. So again, here, this is just highlighting that the role model is extremely likely to be low risk in the future when we account for uncertainty in the risk estimation model. I also wanted to highlight to kind of show a result with another patient who is slightly high risk, because the previous result was for a very, very high risk patient. So now we have a patient who their mean risk score is kind of just slightly above the threshold of 0.2. So you can see with this patient here in the orange, some proportion, maybe looks like about a third, are actually low risk below the threshold of 0.2, whereas 2/3 are above this threshold. And when we look at the role model that was recommended to them, for the most part, the vast majority of the risk estimates are below the threshold, although some of them do end up above it. But either way, the key takeaway here is that our model is able to, again, recommend role models who largely will be low, with high probability will be low risk in the future. And again, this is kind of a parameter you can tune in our algorithm. So if you want to be very, very robust, you can change that as an input to the model. And again, here you can see that the low risk patient, depending on which version of the risk estimation model that they saw that day, they may have been low risk or they may have been high risk. So again, this is just emphasizing kind of the importance of the robustness part of this model. We also compared outcomes based on our role models versus the endpoints in the ACCORD data. So in particular, we compared our role model to whatever the person's measurements were at the end of the trial. And we saw a couple of different trends. So first is when we look at the difference in terms of transformation costs, is the effort required to go from where the patient was at the start of the trial to either our role model or their own endpoint. We saw that our role models actually required less effort to achieve versus the actual endpoints. Whenever we looked at here we call it the out of sample invalid probability. This is like the likelihood that you're going to be high risk when you come back, based on either their actual endpoint or the digital role model. We see that the role models are more likely to be low risk than the endpoints from ACCORD. And then lastly, when we look at the difference in risk reduction, we showed that our role models were able to achieve greater risk reduction compared to the actual endpoints that each patient achieved in ACCORD. So these were kind of our key results. I mean, of course, there's still some fine tuning to do to make sure that, again, that the recommendations are realistic. And of course, this is where working with our clinical collaborators is going to be really important. So we can make sure those are all accounted for in our model. And now I kind of, the last couple of minutes here, want to kind of go back to this slide where we ask, can we design this AI algorithm in a way that is responsible. And so far, I've talked about robustness and interpretability, but I haven't really mentioned fairness. So in the last couple of minutes here, I'm going to talk about some of our work in terms of assessing the fairness of this algorithm, as well as future steps to kind of ensure that we keep doing so. So we developed a model. We kind of performed our preliminary work based on the Accord data. One limitation to this is that the Accord data doesn't really have it's pretty limited in terms of like demographic variables. So what we wanted to do is apply our algorithm to people that we extracted from the NHANES data. So we found about 1,000 patients with type 2 diabetes from NHANES. A little bit more than half were male. And we see that the racial and ethnic demographic is actually quite different in this one. So we have 28% white non-Hispanic, 26% Black non-Hispanic, 32% Hispanic, and then 11% were Asian and 3% were other. We also see that the median 5-year ASCVD risk was 6.9% overall, so quite low compared to the Accord data. And we built our database of potential role models to include people from both Accord and NHANES. So slightly different setup here, but we wanted to kind of assess differences in outcomes based on these different demographic groups, namely gender and race and ethnicity. So when we look at differences in terms of risk reduction, what we found was that if you look here, so these are biolimpostic, kind of show the distribution of risk reduction across kind of, in this case, the males and the females in our data, and then on the graph on the right by race and ethnicity. So if we look at this comparison between male and female patients in our data set, what we see is that the mean and median risk reduction are actually quite similar here across males and females, although the extremes are a little bit different. And when we look at the average risk reduction in terms of race and ethnicity, so what we find is that the mean risk reduction is greater for the white non-Hispanic group than Black non-Hispanic and Hispanic patients. However, the medians are quite similar across the group. So our next steps here are to perform some hypothesis testing to see which of these differences are meaningful. But visually, we can kind of see that, kind of the central tendencies of these are somewhat similar, but the extremes can be a little bit different. We also looked at transformation cost. So this is the amount of effort it takes to go from where the patient starts to our digital role model. And what we found here is quite interesting. So if you look at this gap here between the mean for males and females, and then we look at these gaps across race and ethnic groups, we see that the mean and median transformation costs are greater for males versus females, and for Black non-Hispanic and Hispanic patients versus white non-Hispanic patients. So again, we have to do some hypothesis testing to ascertain which of these differences are meaningful in a statistical sense. But visually, we can already start to see some potential differences here. And then this last picture actually kind of gets into a comment that was mentioned earlier about limitations in the data. So what we found is that when we investigated the number of potential role models for each patient, so here, remember that we're not asking anyone to change their demographic features, and we're kind of restricting our attention to potential role models who have kind of similar or feasible medication regimes. We can see a pretty big difference in terms of potential role models based on the demographics of the patient. So if we kind of look at these 2 points here, you can see that, by and large, the males in our patients and the non-Hispanic white people in our patients had larger numbers of potential role models. And this could be driving the differences that we saw in terms of transformation costs and potentially the extremes of the risk reduction. So, and I think this makes sense. If you have more options in terms of role models, you're more likely to find a good one. So again, this kind of informs some of our thoughts in terms of future work for how to make these algorithms more fair. Yeah, so here I kind of want to just mention that fewer potential role models means you're less likely to find, an ideal role model. And this is something that is, again, a limitation to these types of data-driven algorithms. So in the last few minutes here, I'm just gonna talk about some next steps and then leave a few minutes for questions. So in terms of our next steps, there's kind of two facets of this algorithm that we're really interested in. One is, can we revisit the use of risk estimation models and design those in a responsible way? And then next is I mentioned, the importance of having a lot of feasible role models. And so we want to find a way to generate or find data sources so that our patient database of potential role models is representative across different demographic groups of interest. And that it's large enough where, where most people will have a fair chance at having a good role model. On the risk estimation side, we have started an analysis on designing several types of interpretable risk estimation models and trying to see, whether they're fair, the performance of these models are fair across gender or racial and ethnic groups, among other demographic groupings. And this is kind of a work in progress still, but this is something we've been thinking about. And in terms of other future directions, there's on the mathematical side, we can try to modify our algorithm so that its objectives are fair. But we of course have to try to figure out what that means first. We can also apply more rigorous measures of fairness for assessing the fairness of our models. And this is an important one that we brought on earlier, but gain input from stakeholders on health equity concerns, as well as making sure that the outputs of the models are sensible. And then beyond these, we're looking to extend our AI to accommodate different data sources. You'll notice that the treatments we considered are kind of a little bit out of date. So we want to consider more contemporary treatments, a wider range of adverse outcomes. So earlier, we mentioned potentially kidney failure or chronic kidney disease, not just cardiovascular disease. And we also want to make sure our model can produce multiple digital role models, not just one. And that way, in case the first one you get doesn't really make a ton of sense, you can kind of move on to the next one. So at this point, we have 5 minutes left. So I just want to make sure I'm here to answer any questions that you might have. Thank you for your time.
Hi,
Again,
this is-
so sorry. Go
Sorry,
for it.
no, just you can go ahead.
Right. So again, how does it, traditionally in epidemiological research, we're familiar with things like propensity score matching to identify counterfactual cases. So how is it similar to that? And then I'll leave it to Megha to ask a question.
Yeah, so we kind of accounted for it in two ways. So I know propensity score matching is kind of similar to clustering, right? Where you look at differences between two people and you want to find the most similar ones. So ours is kind of accounting for similarity in two ways. One is the transformation cost. So we want to make sure, and again, we can use, for example, propensity scores instead of the percentile shift that we use there. But again, we just want to capture the similarity in terms of the cost. And then the second is that we do have kind of some imposed similarity in terms of like non-actionable characteristics. So for example, we're not going to ask you to change your sex or your race and ethnicity or change your age, for example. So those are kind of like the different ways that we've tried to account for similarity in a way that's kind of like propensity score matching. To answer your question?
Yes, thank you.
Hi, this is Mega again, and I was just gonna make a couple of comments. I'm a primary care physician, so just putting that hat on. I was just curious if you guys thought about, and it might just be like the limitations that you mentioned of the data, right? But the Accord trial is what you guys use to create the algorithm, correct?
Mm-hmm.
So, I guess that would be my first concern. Like from a health equity standpoint, from a fairness standpoint, because, that trial was recruiting, I imagine, in the mid to late 90s. And just the nature of, we all know there's so many limitations of, or like, what happens in a clinical trial is not what happens in the real world at all, and just the types of people that, participate in clinical trials just look very different than the general population. And I'm curious if you guys had thoughts about, you said, updating the types of medications, because obviously there's been changes in the types of medications we are using now compared to, 25 years ago when that trial started. But consider, more recent sort of data sources that would be more representative of what clinicians are doing in the clinic and the types of patients that they're actually seeing. I think in terms of making this more relevant to how people practice and think about how we treat folks with diabetes and comorbid conditions might be helpful.
Yeah, no, and I agree 100% about that. Like, so a lot of the analysis we did with the Accord data was again largely proof of concept, which is to make sure it's producing results that we think make sense, and just to kind of gain an initial assessment of how well it performs. But before it can ever enter like any type of clinical implementation, like I would love to test this with actual EHR data. And that's kind of been, so, we've been working with Francisco, Hui, and Mary Beth on next steps in terms of we submitted a proposal on the idea, but a large part of that is adding more EHR data to this and kind of developing the algorithm on that. So there's a couple ones that we were interested in based on, what was it? It was an NIH opportunity we saw that came with some data. So we were hoping to use EHR data from that, but I know there's other possibilities as well. Like I think Emory's getting access to like the Epic Cosmos data set, among other ones. So yeah, I mean, for our next steps, we would love to have some real EHR data to train this on and test this with and really assess how it works on different patient populations and more contemporary treatments and medications.
Yeah, very cool concept though.
Thank you.
Hi, my name is Foster. I am relatively new to the group, but in terms of the same in the same line of questioning from the previous speaker, is looking at patients going home, right, post-discharge. I feel like there's a disconnect, right, where we are collecting the data even in EHR. So between these two different types of patients that you are considering, and I know you looked at Hispanics, you looked at Blacks, and you looked at white, but it's not my Blackness that actually contributes to my risk, right? It's about my lack of access, right? The fact that I cannot afford the medication, right? So we may be on the same medication, but patient A, who is the person you are comparing to, can actually afford it, has access to all the primary care providers and everything that a person needs to be able to address the diabetes or whatever the health problem is. And so have you considered incorporating some of these constructs and social determinants of health that actually influence the lived experience, the actual access, the things that shape cardiovascular health behaviors, right? Like, have you considered all those things? Because I think that is where you can actually get to the equity piece, right? That is where you can actually get to the day-to-day post-discharge, what is actually happening to me at home for me to be able to mirror this beautiful picture of an individual you're trying to compare my health with.
Yeah, no, thank you. That's a very, very important piece of it. And like, that was actually part of our motivation for doing some of this like assessment of the fairness of our tool using NHANES, as opposed to Accord. So one of the things we didn't include here because we haven't done it yet, but it's on our to-do list, is to look at like socioeconomic status, for example, like you've alluded to, or maybe even look at things like insurance status and stuff like that, and try to see whether, you know, I guess there's kind of two things we could do. One is assess like, are there differences in how our algorithm performs based on patient's socioeconomic status or other social determinants of health. And then the other thing we could do is also, whenever we're picking a digital role model, and again, this is, we have to think about whether this makes sense or not. But like, we can also restrict our attention to people who are who have similar profile as our high-risk patient in terms of social determinants of health. Again, not to kind of group people and say, okay, well, if this worked for this person who is the same SES as you, it should work for you as well. But just to kind of go towards a more realistic treatment target, you know, that is one possible way of doing it. But yeah, we've thought about it. We haven't done the work yet, is in short kind of where we're at. But yeah, no, I think thinking about other social determinants of health as well is super, super important for the next steps of this work.
And I think you may not even have the answer to this, because one of the limitations or the difficulty with social determinants is even how to measure it, right? And so looking at this EHL data or the existing data that you already have, the variables you're using might already have an inherent bias to it. And so in terms of even bringing in this social determinants piece, how do you think applying that to AI, we can address this concept of bias, right? This concept of, because I remember a long time ago, my computer teacher told me, what you get out of computer is literally like Giggle, right? And his idea of Giggle was garbage in, garbage out, you know? And I'm not a computer geek, but it has stuck with me for a very long time. So when you put bias in, you're going to get bias out. And so how can address this piece as we are even struggling to collect the actual data that matters to patient, and limit these as we go through the AI world, or as we move towards AI?
Yeah, I mean, those are great points. I mean, I don't have an answer for for how to fix like the quality of the data itself. I mean, the best we can do on our side is try to maybe do some pre-processing with the data. But if it's already, like as you said, like garbage in, like as it's collected, then we'd have to maybe think of more creative ways to address it. I know there are, again, like a lot of initiatives to try, recent initiatives like NIH's All of Us data set to try to create more representative and high quality data sets to use for medical research, and perhaps you can consider that as an option. But yeah, it is a very complicated topic, and definitely something that's worth